welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our first presenter is going to be Jessica Dorrough. She's a PRN pharmacy resident at UNC Health Rex. She'll be presenting on emergency department-based education and mHealth empowerment intervention for hypertension.
Before we get started, this is a list of abbreviations for your reference that I will be referring to throughout this presentation. And then getting into some background and overview. So to get us started, this is a graph that illustrates the current blood pressure goals based on the ACC/AHA guidelines. The green zone shows us the normal blood pressure goal, which is a systolic blood pressure of less than 120 and a diastolic blood pressure being less than 80. If someone's blood pressure is above that, then it is considered elevated. There are about 115 million adults who are affected by hypertension at any stage. This is important because about 45% of our ED visits are associated with high blood pressure. And even after being diagnosed with hypertension, there are still 59% of men and 78% of women who continue to have elevated blood pressure. This could be because they are either not seeking treatment, or there is a management issue, or their management is inadequate. And lastly, we know that decreased mortality has been shown with early treatment. So the question is, how do we find these patients and when do we need to treat them? So some background on mHealth or mobile health. mHealth or mobile health is something that became very popular during COVID. The definition is a medical and public health practice supported by mobile devices. The goal with mobile health is to create a patient-centered innovation that is safe and effective. Mobile health has proven to allow for early diagnosis and has helped with monitoring these at-risk patients. Current hypertension guidelines recommend a team-based approach that emphasizes shared decision-making, assessing, and addressing social determinants of health, and consists of communication throughout healthcare teams. So where can pharmacists make these interventions in the ER? So we look at this AIM approach, which stands for Assess, Identify, and Modify. So for assess, pharmacists can be intentionally looking for patients who are receiving orders for blood pressure lowering medications and do a quick chart review to look for hypertension diagnoses, blood pressure medications, and past blood pressure readings from either the hospital or other ER visits. For identify, so after finding these qualified patients, the pharmacist can then find opportunities for improvement in their blood pressure medication management and also make note of potential etiologies contributing to these elevations in blood pressure. For modify, pharmacists can be a part of that shared decision-making and help the provider create a care plan that the patients are agreeable to, and then help the provider counsel and educate these patients on their new medications or lifestyle management. And then looking into that transition of care after the acute care setting, there's another AIM approach. So this one stands for Arrange, Inform, and Monitor. For Arrange, pharmacists can help create follow-up plans with these patients and discuss the importance of these follow-up appointments in their educations. For Inform, this is a crucial part of the process because here we will be able to spend most of our time with that patient that's dedicated to just their blood pressure control. So this is where we can be really intentional about these disease states instead of focusing on others. And then lastly is monitoring. So pharmacists can have patients follow up with them via clinics or MyChart messages to ensure that the patient is being adherent to their medications and their blood pressure is lowering. And then the last background information that we're going to go through are some of the supporting trials that sparked this trial. So the first one we have was in 2014. This was longitudinal study of asymptomatic hypertensive patients with subclinical heart disease in an urban emergency department population. And this showed that at 9 months post-enrollment, there was about 86% of patients that had readings of less than 140/90. The second trial was our AHEAD-2 trial, and this was in 2015. A baseline characteristic that is similar to the trial that we will be jumping into is that out of the 150 participants, 70% of these identified as Black. As for the results, at 9 months, the intervention group resulted in a systolic blood pressure decrease of about 8 millimeters of mercury compared to that control group. Something else to note about this trial is that these patients all had no primary provider to start with. And then looking at our trial, so touched or targeting of uncontrolled hypertension in the emergency department, the goal of this was to compile participants who were both minorities and had less access to healthcare. So to do this, the recruiters had specific training to provide culturally sensitive approaches to this recruitment. And then second, most recruiters did identify as being from minority groups and were generally well accepted to potential participants. So jumping into our trial, emergency department-based education and mobile health empowerment intervention for hypertension. So the purpose of this was to test the effectiveness of an ED-based patient education process on blood pressure over 6 months compared with usual care. And we will get into this a little bit more later, but usual care is just pre-printed discharge instructions and standard outpatient referrals, whereas that intervention is that E2 intervention that we will get into, and then also a referral to a primary care follow-up. They also wanted to address hypertension disparities in an urban ED setting. So the primary outcome of this trial was change in systolic blood pressure in millimeters of mercury from baseline to 6 months. And then some secondary outcomes included change in systolic blood pressure and diastolic blood pressure at 3 months from baseline, the change in diastolic blood pressure at 6 months from baseline, blood pressure control, and then follow-up rates at 3 months and 6 months. So going into our methods, this was a prospective single-site 2-arm randomized controlled trial. Took place in an inner-city academic level 2 trauma center, comprehensive stroke center, and a regional tertiary care center. For recruitment, there were trained research assistants that approached discharge-ready patients by using data on a trackboard. So all the patients that were marked ready for discharge, the research assistants would go into their chart and see if they were qualified, and they would perform screening, which consisted of 3 blood pressure readings that were obtained following the AHA approach for taking blood pressure. So this just included sitting with your feet flat on the ground, in a chair, and then having your arm at heart level. And then all participants were screened and they completed assessments to evaluate their current hypertension knowledge. So some of these assessments included a hypertension knowledge survey that just assessed their general knowledge of hypertension. And then they looked at the modified Morsky scale, and this looked at their adherence to any antihypertensive medications that they were on, if they were on any. They also looked at their ASCVD risk. And lastly, there was a question asking patients if they currently see a PCP. So once they were screened, our inclusion criteria included an elevated blood pressure of greater than 140/90 and less than 180/110 at time of discharge from ED. They had to be verbally fluent in either English or Spanish. They had to be scheduled to discharge from the ED, so they couldn't go either upstairs to the floor or out to any kind of care center. And then they also had to be between the ages of 18 and 75 years old. For our exclusion criteria, they were excluded if they were unable to verbalize comprehension of the study, they had impaired decision-making or documented dementia, if they lived outside of the Chicago community or planned to move from the Chicago area within the next year, if they were pregnant or trying to get pregnant, or if they had COVID-19. So looking at the study design for randomization, there was stratified block randomization in groups of 9 or 6 based on their sex, so either male or female, and then baseline blood pressure. For blinding, outcome assessors, primary investigators, and the statistician were blinding to assessments until after the primary analysis was complete. Obviously, our participants were not blinded. They were either in treatment group or they just received that standard discharge packet. For E2 intervention, they received a visual echocardiogram image clip, and they also watched hypertension educational videos prior to discharge. They also had a smartphone-enabled blood pressure monitoring kit and text messages, which we will go into later. And they also had a post-acute care hypertension transition consultation. And then something to note that we will get into a little bit later is they were compensated. So financial compensation was awarded for each of the 2 follow-up visits, and then all participants also received travel accommodations, so bus passes, ride shares, and any kind of parking validation. So for our treatment groups, we had the usual care, which, like I said earlier, is just that standard hypertension discharge instructions with a referral to outpatient follow-up. And then our E2 intervention included that brief post-acute care hypertension consultation with either a clinical pharmacist or an advanced practice nurse. They also received a smartphone-enabled blood pressure monitoring kit with behavior changes and text messages, and then a primary care referral. So looking more into this E2 intervention group, the mobile health application the patients downloaded and used on their phone was called HealthMate. And they also received that counseling that we talked about. And then they also used this Withings Bluetooth-enabled blood pressure monitoring device, which is shown here on the right. This is essentially an arm cuff that the patient can wrap around their arm and then press ready on the app, and it will take their blood pressure, and it will also record all of their blood pressures in this app. So this can either be sent to their doctor's office or it can just be shown at the next visit. And then lastly, there was 4 behavior change text messages per week plus a daily app notification. So some of these reminders could be either take your blood pressure medications, make sure to use the blood pressure device, and then positive affirmations along the way. So looking into our statistical analyses for our primary and secondary analyses, they were analyzed using a mixed effect multiple linear regression models with unconstructed covariance pattern for our binary outcomes, so our complete follow-up and blood pressure control. The analysis checked for differences between groups using that chi-squared test and showed how likely an outcome was, along with a range to show the confidence that they were in the results. So here they used that 95 confidence interval. For our sensitivity analysis, this was conducted to align with the 2017 hypertension management guidelines. So this included a stricter blood pressure control definition and then multiple imputations to confirm the results. For missing values, missing data was filled in using a method called multiple imputations, which created 25 different versions of the data to make sure that the results were more reliable. So going into our results, so there was a total of 6,945 people who were assessed for eligibility. Out of those, 6,371 were excluded and 574 people were randomized. Some of the reasons for exclusion were not meeting inclusion criteria, not discharging home, having a blood pressure that was not in the threshold when they were doing those screenings, or some people who just declined to participate or who were unable to consent. Out of that 574 people who were randomized, there were 285 people allocated to the control group, some of which did not receive the allocated intervention, or they did not complete all the follow-up, leaving 203 in that control group. And then there was 289 people in that intervention group, some of which also did not receive that allocated intervention or did not complete follow-up, leaving 210 people in that treatment group. So then looking at our baseline characteristics, as you can see, the mean age for both arms in this trial was about 51 years old. For the sex, this is the percent of men in each group, and as you can see, there are very similar, being about 57% of men in that usual care group and 56% of men in the intervention group. Also for race and ethnicity, there was about 72% people who were Black or African American in each group. As for care, about 20% of patients in each group reported not having a primary care provider. And then lastly, looking at if a patient has already on hypertension medications, there was 58% of patients in that usual care group, and there were only 50% in that E2 intervention group. So looking at the primary outcome was changed from baseline systolic blood pressure at 6 months. And as you can see, the change in usual care was 9.3 millimeters of mercury compared to 14.2 millimeters of mercury, making that statistically significant with a p-value of 0.02. And then our other statistically significant outcome was blood pressure control at 3 months, which had a p-value of 0.03. Blood pressure or change from baseline for systolic blood pressure at 3 months and diastolic blood pressure at 3 months, neither were statistically significant. However, that change at 3 months for the systolic blood pressure, I would say, is clinically significant. However, both p-values, that's 0.06 and 0.21 respectively, neither of which are statistically significant. And then that blood pressure control at 6 months, and then both the follow-ups at 3 months and 6 months were also not statistically significant. So looking more into the primary outcome, this is a graph of the raw change in systolic blood pressure and diastolic blood pressure in the observed data. As you can see, there is a much greater change in the intervention group compared to the control arm. The only statistically significant difference, however, is a change in baseline to 6 months in the systolic blood pressure, again with that p-value being 0.02. One thing to mention here are that there were more males who were not controlled, and there were more Black patients who were not controlled. So, however, based on our baseline characteristics, Black or African American patients who were not controlled at the beginning of the trial also made up the majority of the patient population. So this kind of commonality does make sense based on the patient population that we started with. And then these are two graphs that show the mean systolic blood pressure and the mean diastolic blood pressure at 3 months and 6 months for the treatment group and the control group. Again, the only secondary outcome that was statistically significant was the blood pressure control at 3 months. So moving on to our discussion and conclusion, some of the strengths would be the diverse patient population with different chief complaints, multimodal intervention with scalability, similar patient demographics between each group, a high follow-up retention rate, and then using consumer-grade mobile health technology. For weaknesses, one of them was the follow-up was in the height of COVID. This was a weakness because some people were coming in more for COVID reasons rather than blood pressure follow-up or management. However, they were treated with the follow-up and management just because they were there. There could also be potential selection bias, reliance on self-reported adherence to the mobile health engagement, limited generalizability as this was an urban single-center study, and then this study did not monitor changes in blood pressure treatment control after the patient's discharged. So one thing to note that's not necessarily a weakness is that there were more people in this treatment or in the treatment group that were not on any treatments before this trial compared to the people who were in the control group. So this could have skewed the results a little because if more people were started on blood pressure medications in the treatment group, it would make sense that their blood pressure did have the biggest change. That's just something to note. I wouldn't say it was necessarily a weakness. For generalizability, more studies definitely are needed to evaluate the economic benefits of having that extra person in the ER doing this. 80% of the interventions were provided by clinical pharmacists dedicated to E2. And then there's less external validity due to that financial compensation because, again, patients are not going to be paid in the real world to go to their follow-up appointments. So for the author's discussion and conclusion, results of the TOUCH randomized clinical trial suggested that a multi-component education and empowerment intervention initiated in the ED may present a viable and effective strategy for reducing the systolic blood pressure in patients with elevated blood pressure who are discharged from the ED. These findings underscore the critical importance of implementing targeted interventions such as key points during healthcare contact, such as the ED setting, with a multidisciplinary team. And then lastly, such interventions not only address the immediate health needs, but also contribute to a broader public health objective with the potential to improve hypertension management. And then looking at my personal discussion and conclusion, so pharmacist intervention for ED patients may contribute to overall chronic hypertension management. ED visits for unrelated issues can be used for opportunities to screen and educate these patients if they have uncontrolled hypertension. I do agree that it is a good starting block to find these patients, and also it may be a good way to target underserved patient populations who may not have a primary care provider. I think that using technology to send out patient reminders for blood pressure monitoring, upcoming appointments, and refill notifications is something that is currently used, and I think it could be used more. And we could also educate patients in the ER about these technologies so that they are able to use them when they leave. And then lastly, we could implement different education levels for different stages of hypertension. So what I mean by this is if patients have stage 1 hypertension, maybe a handout would be sufficient and a medication adherence conversation just to make sure that they know what they're taking and why it's important. Whereas patients who have severe hypertension may need that full consultation, the app, and close follow-up. So I think a lot of things in this study could be used at most EDs. I just don't know how feasible it is to pull a pharmacist or an APP to every ER to do these E2 follow-ups. I do want to thank my mentor, Dr. Steven Scoverin, and I'm happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.